thanks to the doctor and Rasheda. And I have a couple polling questions I want to ask right away so we can get an idea who is in our audience. And first of all, my name is Mark Rosenzweig. I am a patient since 2013. And we are going to launch this poll right now. So first question is, what medications are you currently taking? And the reason I have to announce is because it does not pick it up on the recording. There'll be a total of 5 questions. All right, I'm going to end this question. And ALKtALK4 obviously is 73%, following up with 11% and 60% for Lantinib, and Practitioner is 11%. And well, you guys can see that right now, right? Okay, I'm going to relaunch a different polling question. How long since your diagnosis? Okay. And it's 25%. Wow, both 1 to 2 years and 3 to 4 years, 25%. The first #1 choice is 31% is 1 year and under, and 5 to 6 is 6%, and 7 to 8 are 13%. So next question. How many number of TKIs have you taken? Indicate if you also have been treated with chemo IV as part of your treatment, and it's multiple choice. Okay, I'm gonna end the poll. Here are the results. And at 57%, 1 TKI has been taken, 2 TKIs, 31%, 24% had traditional chemotherapy, and we have immunotherapy at 10%, 4 TKIs are at 6%. So, and 2 more questions. What stage were you at diagnosis? Can end the poll, share the results. 87% of us were stage 4, stage 3, 11%, and stage 2 was at 2%. Last question. This is kind of a, let me explain this one. If you progressed, what area was the progression? You have multiple choices. If you pick primary, that means that you progressed in the primary location. If you have no progression, you can see that also. So this is a brand new question I've never asked before.
Way to get creative, Mark.
Yeah, so creative that sometimes I don't know what I'm thinking here. Okay, I'm gonna end the poll. Share the results. And this is a little complicated, but no progression, 52% of us have had no progression, which is great.
Wow.
23% are in the brain, which I think is, a national average, pretty normal. And then 17% is in the primary location. 12% are in lymph nodes, 10% are in bone, 8% in lung, 6% in bone, and 6% pleural effusion. Okay, so I'm gonna stop sharing the results, and I'm gonna introduce Deborah Kimmel, and Deborah is a member of ALK Positive, and I'm gonna let her do some of her own introductions. But Deborah, I'm gonna pass the microphone off to you.
It would help if I unmuted there. Good evening, everyone. My name is Deborah Kimmel, and I've had ALK positive lung cancer for 3 years, since January 2018. When I started attending these ALK talk sessions, I approached Mark and Gina and recommended that Dr. Levy and Rasheda Persinger be considered as guests. And I did that for several reasons. Dr. Levy is one of the leading thoracic oncologists practicing today, and he and Rasheda are part of the Johns Hopkins Kimmel Cancer Center, which is a leading cancer treatment and teaching facility. So they are very much at the forefront of cancer treatment. Dr. Levy and Rasheda focus exclusively on lung cancer patients. They treat a lot of patients with genetic mutations, and they treat a number of ALK positive patients. So I feel like the experience that they have and bring to the table, and the ability to share that experience. Hey, Mark, can you go back one slide, Mark, to Dr. Levy's slide? Yeah, missing an actor. Well, find it. See if you can find Dr. Levy's slide. So I think they're a good guest for our group to have, and will provide very good information to you. I put together just 2 slides with Dr. Levy's credentials and Rasheda's credentials. Mark, are you having trouble getting that slide? He's on mute. Anyway, I'm not going to walk through Dr. Levy's credentials. I will tell you that in addition to reading his bio on the Johns Hopkins website, you can go to Google or YouTube and key his name, and you will get a number of hits, because he has been a panelist or a presenter at a number of cancer-related and lung cancer-related events where he has shared a lot of his expertise. So you certainly can do that. On a more personal note, I first met Dr. Levy in January 2018. Like so many of you, I was absolutely shell-shocked to get a lung cancer diagnosis. And that first month is just, you know, as you all know, it's just a blur of procedures and tests and appointments. And when I had my first appointment with Dr. Levy was the first time when I walked out and I looked at my husband and I said, okay, I can deal with this. And a lot of that had to do with the fact that Dr. Levy sat down and just provided fact-based, solid information. He explained my diagnosis. He explained genetic mutations. All of this was a foreign language to me at the time. And he put it into a picture that I could understand and navigate going forward. I'm awfully glad that he's part of my cancer journey, and I'm holding his feet to the fire to stay with me on that journey too, because it's made a big difference. Anybody who is a patient of Dr. Levy's knows Rasheda. Rasheda, in my 3 years, I've observed Rasheda Persinger is the person who kind of keeps all the trains on the tracks. She has a team of 7 nurse practitioners that report to her, and she coordinates patient treatment across a range of different oncology practitioners. So one patient may be treated by multiple people, and Rasheda has her fingers really on the pulse of all of that for all of Dr. Levy's patients. So Dr. Levy and Rasheda kind of go hand in hand and tag team a lot, and I'm hoping that's what they will do this evening as well. Before we turn the session over, Dr. Levy and Rasheda, one of the things that I wanted to be sure, not everybody knows what a nurse practitioner does versus what an oncologist does. So I was sort of hoping that you, Dr. Levy, and then you, Rasheda, would just take a couple of minutes and explain the scope of your day-to-day responsibilities, what you do, how you work together, and to Colin's point, why are you dedicated to lung cancer? So Dr. Levy, if I may turn it over to you and let you go first.
Thanks, Deborah, for those kind words. Very lovely introduction. I'm going to take that and put everything you said on my CV, and so I can reformat my CV for what Deborah said. And so a couple of things that I'll just reinforce. So I'm Ben Levy. I'm a thoracic medical oncologist from Johns Hopkins, and I do see, as Deborah mentioned, I specialize in non-small cell lung cancer. But as fate may have it, I do a lot of ALK rearranged lung cancer and a lot of EGFR lung cancer as well. And we can certainly talk about why I'm seeing so much of that. You know, I started in this field in 2008 after I finished my oncology training in New York City. And, you know, it's an interesting journey because at the time in 2008, nobody was really going into lung cancer. There wasn't a lot going on, but I happened to be very attached to a mentor that was doing lung cancer. He told me that things were going to change. And it's true. I mean, he was like, we are starting to understand. We didn't even know EGFR in 2008. We didn't know ALK. We had no idea. We had hints of it, but we didn't know. So you fast forward now 10 years or 10 to 12 years, and just the pace of genomic discovery and wedded to these targeted therapies has been incredible. It's been an incredible journey for me. My running joke is that I went into lung cancer because it was easy. It was. There were 3 drugs when I started in 2008. There are now 100 different drugs you can give, and that's a testament to the science. It's a testament to the field. It's a testament to advocacy. You guys are on the, you know, you're supporting a lot of this. So I want to thank you from the bottom of my heart. So I'm, you know, very excited to be here. And, you know, my passion is, of course, targeted therapies, but my other passion, I'll turn it over to my nurse practitioner, otherwise known as my boss, and say that it takes a village. And I hope that when you are at a place getting treated, that you feel that there is a team. It cannot be done with one person. No sole physician can do it. It really takes a vision. Lung cancer is just too complicated and too complex, and the patient needs are many. I have this slide that I show that shows the old patient journey, which was diagnosis, treatment, you know, and that's it. And then it is evolved into diagnosis, financial and social situations, you know, getting to the different disciplines, second opinions, all of the things that all of you guys go through in this journey is very complex, and it takes a village. And part of that village, or leading that village with me at Hopkins, has been Rasheda, who's my nurse practitioner. And we have gosh, I wish we could have had everybody on, my nurse navigator, the social worker, the financial clearance office, the integrative care that we used to have that we still partner with. So I will turn it over now to Rasheda just to introduce herself.
Hi, good evening, everyone. Thank you again for allowing us to be involved with your meeting, your ALK meeting. This is such an honor to be here, just to understand your journey as well as understand our role in providing care. I'll go back to Deborah's initial question in regards to what is the delineation between a nurse practitioner and an oncologist. I think what the benefit is, I think Dr. Levy, he's very humble, but he knows his stuff. He knows thoracic. He's an excellent mentor for myself in terms of the expertise. And I think any good oncologist is good for that. But there's other things about the patient's journey that you probably know firsthand that needs a little bit more, I won't say hand holding, but just a little bit more in details. And so Dr. Levy and I work very well together. We balance each other. I like to think that I look at the weeds in the woods, where Dr. Levy looks at the weeds as terms of science, and then we bring that together to provide and impact patient care. I don't think Dr. Levy can say it enough, or any of us that's in oncology can say it enough, that there's no way that there could be one person that could handle and deal with all of the multitudes of concerns and problems and things that arises as you go through this journey. There has to be a team approach. And so I agree with Dr. Levy. It would be great if we could show the whole team, because even just him and I are just part of the team that makes the wheels turn and makes things look so simplistic when it is very complex behind the scenes. I will also follow up on what brought me to oncology. Mine is a personal experience. When I was in nursing school, I had a family member or someone who was like a surrogate family member who was affected by cancer. And though they were not affected by lung cancer, they were affected by cancer. And it kind of just changed my trajectory in terms of what I wanted to go in. So I've done oncology in some aspects since 2003. And I don't know anything else. This is what I do. And so as I migrated through my journey as a nurse, as a registered nurse, and now as a nurse practitioner, the nurse practitioner role allows me to assess patients, to follow up patients, to alternate care with Dr. Levy, to diagnose, to refer as needed, and as always, to have Dr. Levy available if needed to come in to provide a little bit more expertise that's outside of my scope of practice.
I'm going to start with Dr. Levy. Dr. Levy, I have a question for you in regards to the, you were involved in the ALK's trial.
Yeah, early on.
Can you give us a background of what your involvement was and what the findings were of that trial?
I think most of us on this call, probably are aware of the ALK study. This was at my prior institution. We participated as one of the accruers of the trial. Keep in mind that we had a tremendous amount of excitement about Crizotinib coming along the way that it did so quickly. ALK had been discovered as relevant in lung cancer, I believe in 2007, and Crizotinib was developed and implemented in 2011. It only took 4 years, which is pretty remarkable. When you think about other mutations and then the discovery of drugs against that mutation often takes 30 to 40 years. So everyone was quite excited about the Crizotinib story, but along those same lines, once we started to see the benefit with alectinib over Crizotinib, it was clear that some of our patients were on alectinib, given the lack of toxicities and given the improvement in outcomes that patients had. And so, we've learned a lot from the ALK's trial in the past 3 or 4 years. It's been a remarkable run. It still remains a run. It's not over. You're looking at patients who were on, so this was a trial for many of you that don't know, I'm sure a lot of you do, that compared alectinib to Crizotinib head to head and was asking the question, which of these, what we call targeted therapies or tyrosine kinase inhibitors, is better? And what we found in this study was that the alectinib way outperformed Crizotinib. And I just want to mention a few things about nuances of this study. One is that response rates were higher. The chances of tumor shrinkage were higher with alectinib. 2 is that the chances of the tumor remaining in check before progression was much longer on alectinib. And then 3 is that, it's incredible to say this, but we still haven't hit the median overall survival yet. This trial is 4 or 5 years old. And patients, the trend is incredibly favoring alectinib versus Crizotinib. And because of that, alectinib became the standard of care. And this is why most of you in that poll answered alectinib. There are other trials that we can talk about, but the alectinib data, finally, I want to mention 2 more things. One is that the chances of tumor shrinkage in the brain, so there were patients on this study that had brain metastases, and the chances of tumor shrinkage in the brain were much higher with alectinib than they were with Crizotinib. And then, probably underrepresented in the literature is the quality of life is better on alectinib. And so for all of these reasons, the ALK's trial really solidified alectinib as a standard of care. And I say a standard of care because there are other drugs that are making their way. I saw some of the polls that some of you are on brigatinib as well. And so brigatinib was the same trial comparing brigatinib to Crizotinib, similar to alectinib versus Crizotinib. So, and that study also showed a benefit. So those are kind of the updates we see with alectinib, and it's a remarkable story to see how many patients still remain on that study and are doing well on alectinib when this trial was started. So I can't remember the exact date, the inception of the trial, around 2013 or 14. But a pretty remarkable story, and solidified alectinib as the standard of care for patients with ALK range lung cancer.
So then if you're a person walks in through your door today, or not today, tomorrow, actually. Yeah. What is your first line?
Yeah, my first line is generally alectinib, and I think that's based again on the ALK's trial. So I don't want to get too in the weeds with the trials, but just so everyone knows, there's now 3 trials that have compared a next generation targeted therapy to Crizotinib. So there's the ALK's trial that compared alectinib to Crizotinib. There's the ALTA-1 trial that compared brigatinib to Crizotinib. And now we have the CROWN trial that compares lorlatinib to Crizotinib. All of these trials compared the next generation or newer targeted therapy to the old Crizotinib. All three have shown impressive results. However, the reason that I chose ALKtALK4 is because it's got the most mature data. And as Rasheda can tell you, we're very comfortable with dose adjustments on ALKtALK4 and have we've gotten so comfortable using this drug. And most of our patients tolerate it quite well, but 4 pills in the morning and 4 pills in the evening, and making adjustments as needed based on toxicity. So ALKtALK4 is my general first line therapy. That's not to say I don't want to besmirch the folks on Brigatinib frontline. Brigatinib has good efficacy too, and there's some, international investigators who do use Brigatinib frontline. I just happen to use ALKtALK4.
So there's been a lot of discussion over the dosage in our groups. Rasheda, are you going to any ideas of what do you do? I know the standard of care is basically 600 twice a day, correct?
Yeah,
So,
I was going to say I wanted to layer in because I think as we prescribe these medications for patients and patients want, that is the recommendation of the dosage that should be given. And that's what was seen in the study. I think it's also, as providers, important for us to layer in that we have to find quality of life and toxicities weighing it against the dosage, and to reassure patients that you can still derive a benefit even if you have to do a dose reduction. I'm thinking of a patient, particularly where we have had to dose reduce because we thought that maybe it is contributing to necrosis in her brain. Not that she has brain metastasis, but there was some studies, and correct me if I'm wrong, Dr. Levy, in regards to that ALKtALK4 could be contributing to that. And so even with dose reducing, it still controlled the disease within her visceral disease. So I think, as providers, yes, we want to max them out with the medication dosage that was in the trial, but there is still efficacies that we have seen with patients that may need a dose reduction that still derives a benefit.
This is why I have Rasheda on the call, because she can encapsulate better our experience and our dose modifications, but she's absolutely right. And I would say one thing is be your own best advocate. It's okay to tell your physician, look, I know that the data is great with 600 twice a day, but there are some patients who just don't tolerate that. And that's okay. There's still a meaningful benefit with dose reductions. We probably do dose reductions in 25% of our patients. I would say our older patients too, we have several patients in our 80s, maybe in the 80s, not old, but we have some octogenarians who are on ALKtALK4. And I tell patients, patients will come in, even younger patients, and say, I didn't want to say anything, but I'm just, I'm having terrible nausea, or I'm just so fatigued. And I think it's important for the nurse practitioner and the physician together to not dismiss that. There are, challenges with ALKtALK4, even edema or extreme swelling in the legs and the abdomen that we've seen. And so we're okay making some dose reductions, knowing that there's still a benefit with dose reductions. We don't want to get down to 150 twice a day, although we have a couple of patients on 150 or 300 twice a day. But be your own advocate and make sure you voice your concerns so that dose adjustments can be made. It's all about quality, is what I think is so important, what Rasheda said.
So if you have someone who can't tolerate the ALKtALK4 from whatever various reasons, then could you go to Brigatinib, or is that just a lateral move, or how would that work?
These are, I think, what I tell patients is this is where medicine as an art and not a science. Rasheda's told me, say this so many times. It's medicine as an art and not a science. We know so much scientifically, but some of the things we practice have to do with the art of medicine. And I think it's important to be with somebody in a team that knows the art of medicine. We don't have a lot of great data on this. And in fact, we don't have great data. We know from the Japanese data that 300 is the Japanese dose. So 300 twice a day is the Japanese dose. 600 twice a day is the US European dose. And if patients can't tolerate this, we do often consider, I've had a patient who's on 150 or 300 twice a day. And he's like, is it worth it? I'm like, I think it is. And he's like, well, would it be better if I just came and switched over to Brigatinib instead? Maybe I'd be able to tolerate full dose there, and that wouldn't sacrifice therapeutic efficacy. And I think it's a shared decision. I mean, we're certainly willing. I'm open. I take a lot of my cues sometimes from the way patients feel and the way they, what they're interested in doing. I know we don't have a lot of great data on this, but I would consider, if a patient could even tolerate 150 twice a day, I would consider switching them to either Brigatinib or even Lorlatinib. It really depends on the scenario and what the true toxicity is that the patient is experiencing.
So why is the Japanese at 300 and the Europeans and Americans are at 600? I don't
That
get
was based on PK analysis. When you're looking at ways drugs are dosed, you're going to look at the levels in the blood and then the tolerability correlating with that. And in the end of the day, the Japanese population tends to be a little bit smaller and a little less, a little more less BMI than patients, or body mass index, than patients in Europe and the US. So that's how that dose was defined, and it's a higher dose. But I do have 2 Japanese patients who know their data and basically were like, I want 300 twice a day, and so that's what we did, because that's the Japanese dose. But for most of my patients, it's 600 twice a day.
So getting back to the patient knows best from a standpoint of side effects. And a lot of the patients in our group are very, very knowledgeable. And I'm making a blank statement here, which is everyone has their own journey. Everyone has their own side effects. Everyone has kind of like their own, patient to patient, you see a bunch of ALK patients. I mean, my journey and someone else's journey is totally different. So as a doctor, how do you go from one patient to the next? And there's not one blanket,
It's
you're smiling because you know what I'm talking about.
Well, I mean, because I know I'm looking at Rasheda too, because Rasheda is so good at this and understanding how to, we get so busy sometimes that I'm so at the, doing research and everything that I'm going on. I sometimes Rasheda has to pull me in to really kind of elicit the nuances of this particular case. And this is why, again, it takes a village. It takes different perspectives from one team to understand, and it takes listening. Which Rasheda will tell you, she's still working on me to listen fully to what patients are saying, and I think we do a good job. But I think every patient has exactly what you said. I hate to repeat it, but everyone has their own story, and you just have to be careful with that. One patient's story may be very different. So a patient comes in as who's in their 70s who says, this is no problem, I'm on 600 twice a day. And then you see a patient in their 50s or 40s who's saying, I'm really struggling with this. Your job is not to say, how is that possible that someone 20 to 30 years older than you is doing fine and you're not? So I think it takes listening. It's sitting down and really listening to the situation to come up with the best plan. We do that for all of our patients, even outside of ALK. And Rasheda, I don't know if you have anything else to offer.
I saw a question in the chat room. Someone asked, and I think they were following up on our comment in regards to dose reduction. Knowing that patients sometimes may hide some of their symptoms or minimize some of their symptoms in fear of, having to dose reduce, and in their mind thinking that's progression. And I just want to really speak to that's a true feeling that patients do feel like that. And I think that from our standpoint, that is why it's so important for us to layer the field, making sure that they understand that just what Dr. Levy mentioned earlier, as well as myself, is that we are individuals. A study is a study, but you as an individual may be different than the person that was represented in the study. So I think letting patients know, acknowledging what they're feeling, because what you all are feeling is true. It's what you see. You live this. We're on the outside, but you live this day in and day out. You have the family, you have the situation or your family, your friends, your job, or whatever is important for you. So I just think it's so important for us to make sure that we layer in that, yes, our goal is to prolong life. We are wanting to kill cancer as much as we can, but we don't want to do that at the risk of compromising your quality of life. So I think it's just very important for us to just reiterate, to reassure patients that it's okay if we have to dose reduce, and we'll have to take it, scan by scan, symptom by symptom, and see what happens. And if we need to maybe try, because we've dose reduced, maybe we've had a patient off on a lower dose for about a few months, saw scans didn't really show that there was any progression, but the symptoms resolved and the patients wanted to go back up. One thing great about Dr. Levy is that he just doesn't say this word of shared decision making. He really means it. So, a patient comes in and they're advocating for themselves and they're like, look, I really want to try to go back up. He has done that. And we have seen that where patients have been on a lower dose and then increase back to normal. So I can't remember who it was in the chat room, but yes, those are real feelings. And it's important for us as the medical community to make sure that we acknowledge it and try to, as best as we can, to minimize any of those concerns.
So getting back to the sequencing of the TKIs, we've asked some of the other doctors who've been on our ALK talks, when will lorlatinib be the drug of choice to start with?
It's a
Dr.
great
Levy?
question. It's a great question, and we'll have to see how the CROWN data matures. Again, the CROWN data was comparing lorlatinib to crizotinib. What I want to back up and say the obvious, but we all struggle with in our committee meetings, is that there's not been a head-to-head comparison between any of these drugs, between brigatinib, alectinib, and lorlatinib. We don't have frontline head-to-head data, so we're all kind of guessing here because alectinib look really. What we're using is the transitive property. We're looking at alectinib versus crizotinib, and we're looking at lorlatinib versus crizotinib via a cross-trial comparison to see which one outperformed crizotinib the best. And I don't know. I mean, the data with the CROWN data looked very promising because it looked very early on that the signal was stronger with lorlatinib versus crizotinib than we saw with the alectinib data. But I'm not sure. Alectinib is such a good drug. And I don't know how familiar everyone on this call is with the EGFR space, but that is a space where we saw an evolution of frontline care because we had a direct head-to-head comparison between the next generation targeted therapy versus an earlier generation. We here in ALK have 3 next generation drugs that are really good and have all been compared to crizotinib in their own trial, but we don't have head-to-head evidence. And so I also like to use lorlatinib when we talk about sequencing, Mark. I like lorlatinib outside of a clinical trial, post-alectinib. I also have struggles with lorlatinib. So it's weird, I don't know why, but I have challenges giving lorlatinib to patients. It's not as well tolerated in my mind as the alectinib is. And in committee meetings, we talk about paper toxicity and we talk about what's real world and what we see. And when we saw that CROWN data, it looked like it was really well tolerated, but maybe some of the paper toxicities that are listed in columns are fine, but we do have challenges, or I have had some challenges with lorlatinib and I'm happy to share those. But I don't know, it was going to take a lot for me to switch to using lorlatinib frontline. And I, just like before, international and national leaders have different thoughts on this. There are some who feel like it should be used right away. We just don't, this is again, medicine as an art and not a science. We don't have head-to-head data with any of these 3 drugs.
Deborah, I think you had a question.
If I could just add to that, Mark, I also think
Yeah.
we have to understand the side effects that come with lorlatinib. Lorlatinib does have some additional side effects that we don't see in alectinib. Hyperlipidemia, really neurotoxicity that has been seen. So it's not, when and if that does happen, we also have to understand that there are going to be different side effect profiles than what we see with the alectinib that could, compromise patients' quality of life and so forth.
And can I just follow up with the lorlatinib question, which is your dose reduction when you do see some of these side effects? What is the lowest dose that you typically see your patients at?
I've gone down to 50. We've had some challenges with hyperlipidemia, of course, peripheral edema or swelling in the legs and the abdomen. And then we have had a few folks with some CNS issues, some unfortunate episodes of psychoses and depression that were kind of out of character with and this is the thing, this is where, again, it takes a village. You've got to listen not only to the patient, but the patient's family, which is not so easy to do during COVID because they're not allowed in. And so it takes a village, not only from our end, but we want to engage not just the patient, but the patient's family. And this is the reason that I kind of went into this field. So we've gone down, and look, I have a couple of folks who are on 100 and doing just rosy, but some that really struggle with it. And again, because my experience with alectinib is so much more than the lorlatinib, that it's going to take a lot for me to switch to move that front line.
Gotcha. Thank you. Deborah?
Dr. Levy, I'll just let you know briefly, we have run an internal, very informal poll that asked patients that have been at different times on either or both alectinib and lorlatinib. So the only people that could answer that poll that have experienced both.
Yeah.
And I was shocked because we kept reading earlier on, people kept saying, oh, lorlatinib, has this side effect, that side effect. And people were literally, people in our group were scared to go on lorlatinib. And I ran this poll and I was quite shocked. Twice as many people feel better on lorlatinib than on alectinib. And it was not what I was expecting. It totally blew me away. And initially that was sort of a ratio of, the actual numbers were 20 to 10. And I was like, well, it's early in the poll and so on. But we're now at the point where we've got about 75 that have answered and it's about 50 to 25. So
interesting.
Pretty good size sample group now.
That's a great sample. That's a publishable sample group. That's interesting because that hasn't been my experience thus far. And, that may be also a testament to this drug working really well post-alectinib. People feel lousy towards the end of their alectinib journey and then hop on lorlatinib and the drug works really well. I'd be curious to see if you repolled a few, maybe 6 or 12 months down the line, what people would say. But that's interesting.
We've had the poll running for I think it's about 6 months now, and it's been that same 2-to-1 ratio the whole way through.
That's great. I mean, that is interesting, though.
Yeah.
Colin, I would be interested in seeing if there was any way you could do subsets, like those who may have had cardiovascular comorbidities, in addition to their cancer and or lorlatinib. How are their experience with lorlatinib as it relates to some of the side effects?
I can probably talk with you offline about this later on, but we're actually going to be running a very, very sophisticated, deep, IRB approved longitudinal survey that's going to get released quite shortly, and there should be a lot of data that can answer exactly that.
That's great. That's the data we need. It's great. It's all about, again, quality of life. The most underrepresented part of this whole science discussion is quality of life and how patients are feeling. So this type of data and data points are very meaningful, and even meaningful, Colin, for someone like me to look at this, given that there are more patients that you're going to pull than I've seen in my practice. So that'd be great.
So, Mark, do you want me to go ahead and start asking some of the questions?
Sure, go ahead. Absolutely.
And Dr. Levy, if you have any questions that you hear that are kind of patient-specific, if you just kind of convert that to be a more generic answer for the audience, if you know what I mean.
Sure.
So someone has asked here, I have been stable on alectinib for over 6 months. Since progression is likely at some point, should we be planning for that now? And if not now, when?
Such a great question. We get this question a lot. So what to do with a patient who is stable on alectinib, but we're trying to figure out when and if progression happens. And I always tell patients that. So patients will say, so when I progress, I say when or if you progress, because I have plenty of patients who have remained on alectinib since I've known them. And so I can tell them, back in my New York days, I still keep in touch with these patients. So there are many of these patients that just haven't progressed yet or haven't developed disease progression. But I tend not to. I tell patients, the science is evolving so quickly. I don't know what's going to be available in 6 to 12 months. 6 months ago, I probably wouldn't intelligently been able to talk to you about TPX-0131, which is still in preclinical, data. I probably couldn't talk to you about some of the peptide vaccines that are going on. So imagine, let's fast forward to April 2022, there's going to be a different discussion. And so I try to hold off. Some patients really don't like it. They want to know, and I get it. I'm a planner too. I like to know, and I tell patients, we're going to live the question mark. It's a good question mark to live right now. It's tough. I also have a hard time living a question mark, but this is a question mark with maybe an exclamation point on the end. So that's how I coach patients on that.
Great answer. And someone else asked a question. You mentioned early in your presentation today that you're seeing more and more EGFR and ALK patients. And so someone asked a question here, can you expand on your comment on why you might be seeing more ALK patients and EGFR patients?
These are top level questions that I think I would expect from this group, but we don't know. the short answer is we're not sure why we're seeing a tick up in never smoking lung cancer, and why then when you have a tick up or an increase in that, there's going to be more EGFR and ALK. In my region, I'm also, so I lived in New York City and practiced thoracic oncology for 12 years there. Ran the program at Mount Sinai before I moved to Hopkins. And I just didn't have that experience in New York City. And so it may be regional in the DC, Baltimore area, Northern Virginia, Maryland area. It's unclear to me why I'm seeing, I've always, I have fellows who rotate through my clinic who say, I've never seen a clinic like this. This is all driver mutations. This is all EGFR and ALK. What is going on? And I don't think we have a good explanation. We will be doing some research with some of our folks in the lab, looking at potential genetic footprints on the tumor that we can analyze that may be linked to environmental exposures. And I don't have too much time to go over that, but we're looking at ways that in the environment may be playing and how to capture this on the tissue.
Great. And do you feel it might be anything related to just simply that biomarker testing is becoming, as it should be,
Yep.
more prevalent than it used to be?
It is. I still think we're woefully not, we're still not doing as good as we should. If you've heard me talk before, we're still kind of in the dark ages on how successful we are with this. Maybe that's a little bit of hyperbole. But yes, some of this has to do with the fact that more patients are getting accurately genotyped or having molecular testing done.
And just coming back to what you were mentioning a minute ago about you've still got patients that were on the ALKtALK trial that are still progression-free and doing fine on it. We actually had a member just join our group today that has been on Crizotinib with no progression for 9 years.
There you go.
So if you can be on Crizotinib for 9 years, there's surely going to be some patients on ALKtALK for a whole lot longer than 9 years.
I mean, patients say this, or they say, when I progress, I say when or if, like it, I have testament. I have a group of patients that I know haven't progressed yet or haven't developed disease progression. So, it's not an absolute.
I like to quote I had a meeting with Dr. Camage once, and it wasn't a consultation for me, it was just a chat. And I always loved the quote he gave me at the time. He said, "Colin, I'm going to consider you a complete success if you die of anything but stage 4 lung cancer." so my job's to go out and do all sorts of adventures so that I die of something else. Question from someone: would you ever consider going back to Crizotinib after failing on other TKIs?
Yes, in rare circumstances. And we do, I'm sure you guys are aware that there are mutations that can occur post-lorlatinib that are sensitive to crizotinib. It's a game of whack-a-mole where you knock one mutation down and another one comes up and you knock it down again. So it's rare, but the whole idea of sequencing TKIs is a really complicated one. And this mutation L1198F is a mutation that can occur post-lorlatinib and that is sensitive to crizotinib. And we're just still learning about all these mutations. A lot of questions like what to do after lorlatinib and what to do after alectinib. And we're still building knowledge and science on this to wed the particular targeted therapy to the subsequent mutation that's there that you have to identify.
Which brings up a really good point. And this is just me asking a question. It's not on the chat here. But obviously, to detect the submutation that you might have that is sensitive requires biomarker testing, not just at initial diagnosis, but after progression.
Yep.
Yet that is still not routinely covered by insurance.
Yep.
So what's it going to take for us to get to the point where the insurance will recognize that should be standard of care?
I mean, I think we're getting there. I think it's groups like yourselves that are so powerful. I think it's the physicians as well that can really move the needle here. We haven't had too many issues, and we do both blood and tissue on most of our patients. There's scenarios where I wouldn't consider blood, but most of the time we try to do both. But there are challenges with this, and we're not going to move the needle. Patients always ask, or this comes up again in meetings all the time. Do you do both? Do you do one? And, you know, if we're going to build on the literature and we're going to move this field forward, even if, you know, there's a chance that nothing we find will inform a subsequent treatment decision, we need to have this data so that we can move it forward.
So another question here, if you did well on Crizotinib 35 months before progression, is there any relationship to how long you will have on alectinib? So in other words,
Yeah.
if you understand the question.
Yeah, I don't know. I will tell you not a lot of data on this, that patients who have been on crizotinib for a very long time, does that mean they will be on alectinib a very long time? You know, it could be possible given the fact that, you know, there are certain ALK mutations that are just more sensitive to these TKIs. And so there's a possibility. I will say one thing about progression, and that is that one of the most difficult decisions I have to make is whether there's true progression or not in a patient who's on a targeted therapy. And perhaps one of the pearls from this talk is when your doctor's saying, oh, the scan shows growth, it's time to switch therapy. Maybe not. This is where things get very nuanced and very detailed, and where the physician has to look at the scan and say, is there real growth here? I mean, is 2 millimeters of growth really warrant a therapeutic switch? So I just want to put that out there. No, it wasn't part of the question, but I unfortunately don't know if being on crizotinib that long will mean that you're going to be on alectinib that long. I hope.
All right. So someone asked a question, but we've already asked it. Is genetic retesting required for standard of care? It says SOC. I'm guessing they mean standard of care.
Okay. Yeah. We try to do it on everybody.
Yeah.
We kind of talked in the pregame a little bit about the future of ALK medicine, I guess you can call it. And you started bringing up a turning point, which is the TPX medication. Can you give us a little bit of background about the company and the other space that they're in and what maybe this will happen?
Yeah, Turning Point is a relatively new biotech company that's really vested in the next generation targeted therapies, not just for ALK, but for other mutations as well. They have a drug that they just published at AACR for RET. They've got a wonderful drug for ROS, and they're developing a new drug for ALK, TPX0131. This drug is still in preclinical development. You know, it may be helpful to know that a little bit about how when cancers, ALK fusion or ALK mutated lung cancers grow, they can sometimes develop resistance. That resistance can be from two mutations that you guys probably are aware of, but two broad categories of mutations: solvent front mutations and gatekeeper mutations. And those are just a fancy way of saying essentially that the protein from the gene is no longer allowing the drug to bind to its pocket. And so alectinib does a nice job binding to the pocket, but if you develop these two types of mutations, the pocket does not allow you to bind. And these new drugs, specifically TPX0131, are really niche, they're small, and they can get into that pocket. And that's how they were specifically designed and developed, to get into these pockets when these secondary mutations occur. So this drug is got a lot of excitement, because if you look at the data, it looks like post-alectinib, patients who progress on alectinib, roughly 40 to 50% of the time, they will develop either a solvent front mutation or a gatekeeper mutation. And both of these mutations, if they occur, this is where this drug can really work. Again, this mutation is basically resulting in the fact that alectinib just can't bind anymore the way it did before, and these newer drugs can. So it may be niche, but Turning Point has a success story with ROS, at least right now. We have a drug called Repotrectinib, which is a drug that is developed specifically post-crizotinib for ROS rearranged lung cancer, and the drug looks very good. And it was specifically designed the same way that TPX0131 is being designed. It was designed for the same sort of solvent front or gatekeeper mutations, but for ROS, and they've been very successful. So we're going to have TPX0131 It's not going to be in our hands probably for another 6 to 12 months, but I look forward to it. So I think that that's one way to tackle resistance, is develop these new novel niche drugs that can bind in the pocket. The other way that I think that we're still looking at is with immunotherapy, and I want to be very clear that immunotherapy as a single agent is probably not the best drug for ALK rearranged lung cancer. I've had a couple of people who've done well, but immunotherapy as a single agent is not probably the best way to treat an ALK rearranged lung cancer. But there are combination approaches that are being looked at and explored. I mean, we'll see some early signals to see what happens. There's also combinations, there's different types of immunotherapy that aren't yet approved. So we've got things like peptide vaccines that you may have already heard about from the other folks that have joined that also may help tackle resistance. So I look at the resistance therapies as the newer next generation targeted therapies that go against solvent front or gatekeeper mutations, and then sort of immunotherapy and the immunotherapy combinations that can occur, either some of the standard drugs we have or some vaccines that are being looked at, and MGH is leading some of these as well. Lastly, I'll say that, I know that we feel that chemotherapy is a bad word, but there are many patients post any targeted therapy who do extraordinarily well on chemotherapy. It's not my first choice, it's not, but there are some patients who have very long tails on chemotherapy, specifically a drug called ALKtALK4, which we know works extremely well for ALK rearranged lung cancer, very well tolerated, given 15 minutes over, every 3 weeks, 15 minutes, well-tolerated drug. So those are the kind of the categories I look at when you think about.
I mean, I concur, because I post this a lot on Facebook, where I had 8 months of chemo to get me to the phase 2 Lorlatinib trial.
Yeah.
And that was 4.5 years ago, and I'm still here on
Yeah.
that same drug.
Not a bad
So,
word. It's
not a bad word.
Drugs. Yeah.
You need
And
it.
Dr.
But
Levy, could you speak to the fact that even when you start patients on chemo, depending on where their progression is, that you would continue them on the oral therapy as well?
Yeah, it's a great point, Rasheda. Sometimes when patients do have to go on chemo, either because they're waiting for a trial or we think it's the best drug for them, sometimes we will continue the targeted therapy and add in the chemo. This is where things get extremely nuanced and detailed. And this is where Rasheda has to remind me sometimes, did you continue the TKI? So, I mean, it does take a village, and we really try to, it's nuanced, and it's medicine as an art, not a science. And I think we're just beginning to scratch the surface with the science here and what to do after alectinib or after lorlatinib or after brigatinib.
And what is your experience with, if someone has been failing on TKIs, they go on chemotherapy, of it actually kind of resetting the cancer where they can go back onto a TKI and it's effective? Have you had some experience with that? I know it's not common, but I've heard it does happen.
Yes, limited experience with this. I mean, borrowing from the EGFR literature, there is experience where once patients have a TKI break and they get chemo, the cancer can be resensitized to the TKI that they received prior to the chemo, depending on how long the chemo was on for. The longer the chemo, the more likely potentially, if it was a year ago and the patient's been on chemo for a year and they came off of alectinib for some reason, and then yes, there's been some data to suggest that that tumor is resensitized to alectinib. So not a lot of great data. Medicine is an art and a science, but certainly worth exploring. I would just say every patient's so nuanced and so individualized that, as Rasheda was mentioning, as we talk about nuances of toxicity with patients, we're also talking about nuances of their treatment pathway.
Great. And I think you've kind of touched on this a little bit, and I think I know what you're going to say, but just for the benefit of everyone in the audience, if someone needs to, well, I'll rephrase it, but if someone's, here's the exact wording of the question, but I'll rephrase it. For dose reductions on alectinib, do you titrate down or stop and restart for maximum relief from side effects, in brackets, fatigue and myalgia? So yeah, my understanding, but please feel free to say otherwise, my understanding is that you would only stop if there's kind of life-threatening toxicities. Whereas if it's things like, fatigue or myalgia, that would be a matter of dose reduction in those cases.
Yeah, Rasheda, I don't know if we've ever stopped somebody cold turkey on alectinib.
No, I can't recall. We've always dose reduced and then just kind of reassess that. I don't know. There's not a patient that's coming to my mind that we've just stopped just based off the side effects.
So here's a question for stage 3 lung cancer. The patients have alectinib after the surgery. Do we have a clinical trial to test whether that's a good thing to do or not?
We don't have a lot of great data on this. There's some trials that are being looked at. I mean, the question really, the broader question is similar to EGFR. These drugs are great for advanced stage patients. Can we leverage it for earlier stages? And I think we should. There's going to be some movement with a big global national trial called the LCMC4O, which is essentially looking at alectinib and other targeted therapies for early stage lung cancer, resectable stage lung cancer. But the stage 3, we're still kind of wrestling with what to do for ALK rearranged lung cancer. I can tell you that patients with stage 3 who are ALK, I don't have a lot. If they get chemotherapy with radiation, I would consider, although it would be heresy among other investigators to say this, I would consider potentially putting them on alectinib, although we don't have a lot of great data for it.
Okay, thank you. Yeah, I think, I guess we get to hear the stories about, because, if someone gets a theoretically curative treatment, they may not even join our group, whereas I think once they're stage 4, then they're like, more likely to join.
Yeah.
So it's a little hard to say. There's a really insightful question here from gal Suzanne. What are the progression rates for the Japanese on their different alectinib dose relative to the rest of the world on the international dosage?
I'll have to pull up the Japanese data, but they were relatively similar. It may have been a little bit less for the Japanese, but I can look at their PI. I don't have the Japanese data up, but they're close. They're close. The 300 twice a day in the Japanese patient population versus the 600 twice a day in the US, relatively similar progression-free survival rates. But I'll have to look it up. I don't have it off the top of my head.
And I'm going to ask you a question that's my own question here related to that. As you would be aware, it's not uncommon if someone's getting progression only in the brain and not in the body, to increase the dose even above 1,200 milligrams as high as 1,800. Do you know whether the Japanese are doing something similar? And if so, are they doing it from 600 to 900, or are they going even higher than 900?
That's a great question. I don't know the answer to the Japanese data. And if they're going, yes, there's been some data to suggest, I hate to use the word failure, but that when there is lack of penetrate, or when there's potential growth in the brain on a current dose of alectinib, if it's a small amount of growth, we often just radiate it. But if there's true growth, you've got two options. You can either bump up the dose of alectinib post the therapeutic dose that you started with, or you can switch them to another TKI. This is one of the more challenging scenarios that we have. I don't know in the Japanese literature, did they go up for disease progression only in the brain, and what the results were for that. It's a great question.
Great. So question here, what do you think are the most promising avenues of new research for ALK lung cancer? How about the most promising clinical trials for people who have exhausted their TKI options?
Yeah, I think I alluded to this earlier. I think the next generation targeted therapies like TPX0131 are going to be a game changer for the right patient. It may not be all patients. So I think that's one area where we're really making a lot of movement and traction. I think the other one that's coming about is harnessing, we're very new in this, but harnessing the patient's own immune system to turn against the cancer. And why we haven't been able to do that successfully thus far with ALK is a whole nother story, but potentially having vaccines that can, turn the immune system against particular types of ALK mutations is one area where we're going. So I think that, I'll tell you another one that again is not super exciting, but it's gotten a lot of traction, which is adding chemotherapy to TKI up front. Again, chemotherapy, I know is historically thought of as just bad and it's a lot of toxicity and it's challenging, but there are many patients who do really well on chemotherapy, and even adding in chemotherapy to an ALK-directed therapy may be the way to go. I mean, I've got a lot of thoughts on this, and I know we've got a lot of questions, but I got a lot of I have a feeling where we're going to be heading with this, but we'll see.
Do you have thoughts on other newer technologies that are maybe further out, like CRISPR and CAR-T therapy and all that sort of thing?
Yeah, I think it's an incredible movement with CRISPR and truly understanding gene editing and understanding the genomics of the tumor. And even I didn't even mention like something like CAR-T, where we're beginning to take a patient's immune cells out, genetically re-engineer them to go after the cancer, and then re-infuse them. So yeah, that has not made a lot of traction yet clinically in lung cancer, but I think in 10 years from now, we'll be talking about this.
Okay. Another question here. I am on 125 milligrams of lorlatinib. So not 50, not 75, not 100, but 125.
Okay.
And manage the side effects with a palliative care team. I feel better on lorlatinib than alectinib by a lot. Don't be scared. Everyone is different. I guess that's not a question. It was just a statement. Okay. Do you see any patients that have both ALK and EGFR?
Rare. I've had one in my whole career. I think we wrote it up. But they're there. They happen. And what TKI to choose is a challenge. Do you go with an EGFR-directed therapy or an ALK one or both? This is rare.
And so if you had that patient, what would you consider trying both?
I would be a little concerned about, it would depend. I would do something. I'd look in the blood and I'd look to see which variant allele fraction was higher. Was it the EGFR or the ALK, which is also tricky. I may consider doing both at dose reduced levels. I may, and escalate up if need be.
Okay. So here's an interesting question. You mentioned some mental health as a side effect of lorlatinib. Have you found similar symptoms on alectinib?
Not like lorlatinib.
Yep.
Not like lorlatinib.
Yep.
You think it's because the penetration of the lorlatinib into the brain is higher?
No, I just think that this side effect that we're seeing with lorlatinib is different. Again, my experience with lorlatinib may be very different than others, but we've had a couple of patients who've had some true psychoses that I just don't see with alectinib.
Question here, can you talk a little bit about post-lorlatinib treatment strategies, especially if the patient has progressed relatively quickly on both alectinib and lorlatinib?
This is unfortunately a scenario we see, and we're just learning about what to do. I can tell you off trial, again, not a sexy reply, but that chemotherapy, I've had a couple patients like this where I can't get them on trial because the progression has occurred too quickly, where they've gotten alectinib and then lorlatinib. This is where we do give chemotherapy to cool them off a little bit and wait for the next trial. This is also an important call to look at mutations. As I mentioned to you, there are mutations post-lorlatinib that are sensitive to crizotinib. The L1198F mutation is a resistance to lorlatinib, but then has restored sensitivity to crizotinib. This is where the trials are going. This is where TPX0131 is going to make a difference, I think. This is where potentially immunotherapy combinations, I know that sounds vague, but we're just scratching the surface with what to do post-alectinib and lorlatinib. And I can tell you, for a patient who's progressing quickly on both, I would really probably give them chemotherapy first, and then think about clinical trials after the chemotherapy hopefully would cool things off.
And would you be doing that with chemotherapy combined with lorlatinib in that situation?
If the progression is really quick, probably not. If they didn't derive any meaningful benefit, probably not. But I would consider it if the patient was on lorlatinib for 6 or 7 months, sure.
And if it was quick progression, would you consider just chemo on its own, or would you consider chemotherapy with immunotherapy?
I would. One of the most controversial therapeutic strategies is which chemo. I generally do carboplatin and pemetrexed alone. I don't add in the immunotherapy, only because if you're going to add in that immunotherapy, it may cause harm when you're going to reinstitute another tyrosine kinase inhibitor or targeted therapy.
Great answer. So changing track a fair bit, there's a question here. how often do you recommend a PET scan versus just doing CT scans?
So it's a great question. I usually don't get PET scans unless the CAT scan is showing something, equivocal. So I do CAT scans on everybody every 3 months. I don't do PET scans. I will consider doing a PET scan once a year on a patient. If patient's like just wanting to take stock and see where we are with things, or if the CAT scan is like showing something equivocal, then generally I do PET scans, but I don't do a PET scan every 3 months. I do a CAT scan. Also an MRI of the brain every 9 to 12 months in the absence of symptoms. And everyone's got their own interval. There's no data on this, but I tend to do it every 9 months.
Okay, yeah, I think, we kind of recommend to the members in the group to no more than a year anyway. So, yeah. And next question was very similar. I'll ask the question. I think you've already addressed it, and I'm not sure that you've got anything more to add, but maybe, what can you say about a future lung cancer vaccine and your take on it?
I think we have historically failed at vaccines up until the 90s and early 2000s. I think the technology is getting better. Obviously, even if we take ourselves outside of cancer and look at how we're succeeding with vaccines with viruses, I think that there is going to be a niche here. We'll see some of these peptide vaccines that are loaded in and can generate an immune response against a particular mutation that causes resistance for targeted therapy is the way we're heading. It sounds great on paper. It works beautifully in mice. But as many of us know, what sounds great on paper and works beautifully in mice doesn't necessarily translate into the clinical realm. But we'll see. Longevity has sponsored. I'm on the Longevity Advisory Board, and certainly we've looked at some of these grant proposals for some of these peptide vaccines for ALK, and I think it's a way to go. I think there is a way to harness the immune system against ALK-rearranged lung cancer. We're just not there yet, but we're getting there.
So, and I think you're aware that we've got one phase 1 clinical trial starting for an ALK vaccine towards the end of this year.
Yes.
With Dr. Mark. So,
yes. Yeah, I think that's some of that is through longevity. I think he presented that, but so that'll be great.
Yeah, that's all our funding and our selection, but because we weren't a 501c3 when we did that. It was all through longevity. So.
Yeah.
So here's a question. I was diagnosed stage 3A at Hopkins. I had a lobectomy and adjuvant chemo and radiation. I went almost 3 years after without taking anything before I had progression. Oh, I guess it's not a question. That's when I was put on alectinib. So anyway.
We just don't have great data on how to use alectinib post-surgery yet. I wish we did.
Mm-hmm.
It's a very controversial thing.
So I'm trying to find some questions here that haven't been asked already.
I do have a question just for Rasheda, and that is, I see my nurse practitioner a lot more than I see my doctor. The role that you play, is that more of a role where you are seeing patients just getting medications and not really during scan intervals, or how's that relationship with the patient?
So ideally we do, we alternate follow-ups, and it is ideal for the patient to see the oncologist on the scan visit. However, there are sometimes, especially when scans are completely stable or we have regression and it's a very straightforward scan, I will see that patient and follow up. But our goal is that we usually try to get the patient to be seen by Dr. Levy on their scan visit, and otherwise we just alternate.
Gotcha.
Mm-hmm.
Well, I know we're running at 8:12, and we told you we were only going to keep you for an hour. We've gone overtime. But Dr. Levy, can you tell us a little bit about your podcast? I've been kind of like haunting you and looking at you through the internet. So give us an idea how we can listen to your podcast, because I think they're very, very.
We've done a few. I did, these are through Hopkins, and I do some of these, and I've been interviewed as well. But I can tell you actually the best podcast video that I've ever done that talks about our team and it takes a village and how to navigate is with me, Rasheda Persinger, and Candace Graham Adderton. She's our nurse navigator. We did a video panel discussion, live, which seems crazy now. There's something called an audience there, and there were no masks. It was pre-COVID. It seems like 20 years ago, but it was like 2 years ago. And it was so great. And you should, I can't, it was the living room, which is out of the Adario Foundation.
Yes.
I did that. And then Rasheda and I, you can just look Hopkins, Levy, Persinger podcast to really get a sense. But that living room panel discussion was great because it really talked about the journey for the patient. It wasn't focused on ALK, but it did focus on just the journey and everyone's role here and how patients can be their own best advocate and how they need to be sometimes, but that how it takes a village to get everyone through this process.
Yeah, I really appreciate that, the village concept, and our little ALK family here, where our Facebook group is just amazing how much information that we can pour at each other. Deborah has been very silent. I don't know if she's, I'm giving you the final words, Deborah. Where are you?
Well, I will take the final words, and
All right.
to be honest, I'm hoping that Rasheda and Dr. Levy have their chat boxes open and are seeing some of the comments, because a lot of appreciation being expressed. I think I told you both that not everybody has a Johns Hopkins in their backyard like I do, and I'm telling you, I'm grateful every day for that. But this kind of forum is hugely valuable for all of us, and there's a tremendous amount of group energy in this ALK positive group. And when I was first diagnosed, Dr. Levy told me, I don't know if you remember telling me this, that I was going to find that ALK positive patients are out there, energized, committed, and terrific advocates for themselves. And I think this ALKtALK session is a great example of that. So I hope, Dr. Levy and Rasheda, you've been reading the comments, see the appreciation. And I want to thank you so much for being so gracious when I reached out to you after talking with Gina and Mark, and sharing your Sunday afternoon, your Sunday evening with us. Thank you.
Thanks, guys. It's been a pleasure.
Thank you.
It really has. I really want to thank you for all that you're doing. I meant it when I said it to Deborah. You guys are well-oiled machine in the best way possible. And you really are out there advocating, and your collective wisdom is driving a lot of this. So I want to thank you for what you do for not just the patients, because you guys are such a great group, but what you're doing for the field. Thank you.
And I would like to just echo that and just add to it. Just keep your foot on the gas. You are definitely making a difference, even if it doesn't seem like it. So don't let up. Don't let up on your oncologist. Don't let up on the questions. Don't let up on stop asking what you need to. You are definitely making a difference in the world of oncology as it relates to lung cancer.
Thank you so much for coming in on Sunday at Sunday night. This well-oiled machine. I have one more announcement before we let the Rasheda and the doctor go. That is, next Sunday is one we're going to talk about ALKtALK, which is going to be another fundraiser, so we can fund great research for Dr. Levy to find a cure for us. Are you on board, Dr. Levy?
I'm there.
All right.
All right.
I know Colin's on board.
Thank you.
So, and thank you so much. And we really appreciate you, and thank you. Anyone else?
Thank you.
Keep up
You
the
guys
fight.
can unmute yourself and.
Thank you, Dr. Levy. Thank you, Rasheda.
Thank you.
Thank you. Thank you, Deborah. for
Thank
inviting me.
you.
Thank you.
Thank you.
Thank you. Thank you very much.
Thank you.
Thank you, Alexei. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
More and more familiar faces now, about
Thank
seven
you.
or
Hey,
10.
guys, we'll see you next Sunday. Be there for that meeting. We got to raise some money.
We have nowhere
Yeah.
else to be,
All right.
honestly.
Yeah.